Objective of our session is delirium. So at the end of this session, you would be able to define, recognize, and diagnose delirium, and know the ways of treatment. So delirium is an acute confusional state, and it may occur over a short period of time, and there is always a cognitive decline in the patient. If you look at the delirium description by diagnostic criteria in DSM-4 text revision, delirium defined as presence of disturbed consciousness. Patients would have reduced ability to focus, and their ability to shift attention is diminished. Change in cognition, such as memory deficit, they are disoriented, and their speech is disturbed. And there's also the disturbance is not accounted by pre-existing condition. It's most likely due to acute changes. A lot of time you would know that patient have underlying dementia, and all of a sudden there's like behavioral change. The disturbance, as I said, happens over a short period of time. In general, several hours to days, and the change in cognitive function fluctuates during the day, especially worse at night. I want to repeat myself again that this is a combination with what patient has as a underlying, the chronic illness. It could be chronic illness such as dementia, and magnitude of the precipitating event. The delirium is a very costly situation and can cause long stay in hospitals, and it is correlated with increased morbidity and mortality rates. In this graph, you see on the left side patients with like you and me, like let's say this 0 point would be like healthy patient. Towards the end, more like the other factors being added, like age, cognitive impairment, frailty, chronic illnesses, so you can add on. If you look at the upper, the insult intensity, for a healthy person to develop delirium, you need very strong insult, okay? You can't tip them over easily, right? And for 90-year-old frail with like mild, moderate dementia or dementia, like more advanced dementia, a small insult can cause delirium, such as, as small as constipation, to urinary infection, or like, ischemic changes in the brain. As I said again, the cost of the delirium to our healthcare system is around $100 billion per year. And if you look at the rates, 30% of the patients, hospitalized patients, may have delirium. It's a big number, and associated with prolonged length of stay. In another entity is cancer. In cancer patients, we may come across delirium as a symptom, and it is not rare in patients with advanced cancer. especially if you look at the studies, and the rate of delirium is between 14 to 55% in hospitalized patients with cancer. 75% of the patients who had bone marrow transplant may develop delirium. We don't see those patients because we don't see much patients right after bone marrow transplant, but I used to treat them. 90% of patients with advanced cancer may have delirium during their final weeks of life, as we see in our floor and during our consults. And based on the study where there were 43 patients with advanced cancer followed in an oncology ward, delirium, 70% of the patients had persistent delirium at discharge. And 23% had severe delirium reduced to mild to manageable level at discharge. And when you look into the etiology of delirium, it could be like cancer, dementia, chronic illness combination, but a patient with cancers, the most found factors were like brain mets or primary brain cancer. Medications that we use, especially medications such as anticholinergics that we use to decrease secretions, like scopolamine patch. Glycoprolate does not cross blood-brain barrier, but with indirect effects can also trigger. Opioids, narcotics, and sedation, benzos. Infection, metabolic changes, as you know, dehydration, hypoxia, low oxygen levels, and poor perfusion, poor circulation. Anemia, nutritionally compromised patients, and organ failures like liver and kidney. The delirium, although by the definition there's cognitive decline, but it may present in different forms. One is like hyperactive, the other one is hypoactive, and the mixed form. There's also a new definition like normoactive delirium. Hyperactive delirium presents with psychomotor agitation, and 22% of the patients may present with hyperactive delirium. So it is mostly known, but it is not as wide as hypoactive delirium. Hypoactive delirium is seen 46 to 50% of the patients with delirium diagnosis, and in hypoactive delirium the symptoms are different. I'll come back, and there's a mixed form combined with hyperactive psychomotor agitation and hypoactive symptoms. So the diagnosis is difficult actually, and we all miss hypoactive delirium. Hyperactive delirium is easier to recognize, of course. The behaviors are, like restlessness, and they try to come out of bed, like you have seen many times in our ward, despite of what you do, and they are agitated. They may scream, they may pull the lines, and that's easier to figure it out that patient has delirium. Hypoactive delirium, as I said, most missed situation. When you look at the patient has some sort of like slowing. They can smile, they may say yes, whatever you ask, and you think that she's okay, like this little demented lady sitting in the bed, and you may just miss the situation. You need to question more, and if you question more, you see there's inattention and there's decreased awareness to the environment. And that patient is actually under risk for developing hyperactive delirium too. And some of the cases called as persistent delirium, you can also find another term like terminal delirium. Based on the studies, and one of them is here, they checked 412 patients. They had delirium at admission. They followed this patient over a year as an outpatient, and 1/3 remained delirious up to 6 months and required medications. And 1 year mortality was in this patient group, it was 39%. So if you have patient you're trying to treat for delirium, inpatient, outpatient, and it's pretty difficult to manage, you know that this patient may have very poor prognosis. Of course, depends on the underlying disease, cancer, dementia. So what is causing prolonged delirium? Why they are so, it's so difficult to treat? Of course, we look at the systematic reviews. There are some good reviews, and this was the best, published in 2010. So persistent was associated with dementia, increasing numbers of medical conditions. The more complex the case is, higher the risk for persistent delirium, and if they are presenting with very severe delirium, it may be persistent, and they may have hypoactive symptoms. So patients with hypoactive symptoms, mostly missed, may have like persistent underlying delirium due to their chronic illnesses. And patients with hypoxic illnesses, like very advanced COPD, may have persistent hypoactive symptoms. So how are you going to diagnose delirium? You are the palliative care specialist, you're trained in the field, you should have your antennas more sensitive to diagnose, although we see delirium in many settings. Could be like in intensive care unit after following big surgery, or liver transplant is sort of famous cases. So basically, this healthy patient had big abdominal surgery, may have it, to a patient 95-year-old with dementia and pulling lines and screaming. So of course we all need to do a good histophysical exam, document, right? You have to rule out infection. Infection could be number one reason in hospital setting, or even like in home setting. If you're visiting patient at home, you're a hospice clinician. And put together all your neurologic findings, your neuro exam, focused neurologic exam. You don't have to do like the full neurologic exam, but it is a must. And laboratory findings can be very useful. Should we order neuroimaging? Like we have patient comes to emergency room, admitted to our floor, or like we are admitting from home for a patient who presents with delirium. And they have done studies to understand what do we really need to check the MRI, because if you call neurology consult for delirium, they are going to line up MRI of the brain, comprehensive panel, this and that. So, so there was one study, impressive, the new publication. 279 patients had CAT scan of their head after finding delirium, and they were older than 70 years old. And of these group, like 15% had acute central nervous system disease, something happened. And then of those 15%, 40 had new neurologic findings, focal change, and significant change in their mental state, like they are not able to speak, like aphasic, they cannot follow the commands. So if you look at the, like maybe 15% of the patients may present with some sort of CAT scan finding, but only the positive CAT scan finding correlates with, real significant clinical changes, which is like 50% of positive CAT scan finding correlates with clinical exams. So very, very small group. It is really clinical judgment, and you have to think based on the context. So you have a patient who has delirium as an acute presenting symptom, and you don't know the patient, of course you need to get neuroimaging. But if you have hospice patient who is known has metastatic cancer, maybe having some urinary infection, pneumonia, or some is approaching the end, you don't have to do neuroimaging. It's not very useful. So what do you use? I mean, you can still use certain tools, and it's so easy. One of them for patients with hypoactive delirium, able to somehow communicate. Of course, this is not applicable to a patient who is very agitated. You could check mini mental state examination, or then check those domains if you can. It's especially used for demented patients with very mild symptoms, just to understand fine changes. The most commonly used tool is CAM, the Confusion Assessment Method. It has 4 key features. It's widely used in ICUs and in many inpatient units like geriatric wards. We are really not using in our floor constant screening, or evaluation tool, although it's available. 4 key features. So you look at the change in mental status and with fluctuations. So patient has that, right? Inattention, yes. With these 2 and from the below, one of them can help you to diagnose delirium. You can say, yes, there's delirium. So first 2, and then either disorganized thinking or altered level of consciousness, right? So it has 95% sensitivity and specificity. Very simple. 4 domains, 2 of them back. Acute change in mental status, inattention and either disorganized thinking or altered level of consciousness. And another tool, MDAS, you will come across with this tool in different settings. It's widely used in many inpatient palliative care units, oncology floors, the Memorial Delirium Assessment Scale. Terry knows Dr. Breitbart, right? Terry, developed by him and his colleagues, a brief tool for assessing delirium, especially in medically hospitalized cancer, and it was created for also HIV patients, AIDS patients in the past. It is very applicable for all other disease conditions, and it does include psychomotor activity, which is the difference from CAM. So it could be a tool to diagnose delirium. It could be a tool to monitor your treatment. So you can do it daily, and it can even create graphs. There's actually a program access file you can obtain from MD Anderson. It can really help to document your interventions. So we talk about the etiology, the epidemiology. So it would be easier if we can prevent the delirium, because we know that the treatment is kind of difficult once it's there. Especially in our field, I'm not talking about like acute delirium we see in med-surg floors and ICUs. It could be also difficult, but much easier to control. So there are recommendations, a lot of studies done, and then based on the recommendation, this doesn't show the title because the program is old version, and what I use is kind of newer version of program. Anyway, so if you have patient mini mental state exam score is under 20, patients who has sleep deprivation, they can sleep, and then existing cognitive impairment, they are bedbound and they have visual impairment, hearing impairment, dehydrated, electrolyte imbalance. All these patients are risk for developing delirium. And once you know the risk, so you can kind of intervene, but the research evidence on effectiveness of these preventive interventions is not much. And one, like the most, kind of concrete evidence comes from a patients, hospice, elderly patients with, like after hip surgery. We know that elderly patients who can develop delirium after hip arthroplasty or replacement. And I had one very dramatic case here recently who had the hip surgery, was delirious. We intervened, they called pain management was involved, so he was getting pain management. Of course, the pain medication can increase the delirium. So his delirium became persistent. We are giving all this medication, eventually controlled, but he died. So you know that if that happens, the mortality risk is high too. Screening patients for delirium, especially in geriatric wards, in palliative care, hospice units, could be very cost effective, so you can prevent. And when you try to obtain this information, it has to be also good collateral information obtained from relatives and caregivers. So you cannot just predict based on like lab work or previous risk factors only. You have to talk to family or caregivers. Their home health aid even can be useful. So a simple question directed to a patient's friend or relative. You ask, do you feel that he has been more confused lately? It's a very straightforward question, and if it's yes, has shown to have sensitivity of 80% and specificity of 71%, and high negative predictive value is like 91%. If family says no, this is what she is, like she has dementia for 10 years, she's bedbound. I mean, I haven't seen any, a behavioral change, or like I haven't seen any confusion. She's the same way as she doesn't remember things, so it is unlikely. So you ask your questions, you look at the lab work and done all and diagnose the delirium, and you need to kind of come up with a plan. How are you going to treat the delirium? You have to act. It's in a kind of urgent situation. Is delirium an emergency? Yes, it is an emergency. And because it's a commonly treated as a symptom or the condition in hospitals and in elderly, in many other settings, in nursing homes, American Psychiatric Association has, developed best practice guidelines. Same in United Kingdom, National Institute of Clinical Excellence, called as NICE. These two institutions have some guidelines. Guidelines are not set rules. It is actually recommendations. So there's actually no FDA-approved medication for delirium treatment. Did you know? So initial management is, first of all, although we know there is no one reason that patient would get delirium, it's likely multifactorial. Still, we need to look at the precipitating factors and then try to treat those factors. If it is infection, treat the infection. Hydrate patient, if they hydrated, electrolyte imbalance, hypercalcemia, treat those conditions. Ensure effective communication and reorientation of patient, and then provide like same staff members, you know, so to prevent further confusion, and if possible, get the family and friends involved. It can really help patient to relax. And if you feel like the delirium is part of the dementia, it's not a delirium, it's a dementia, whatever, you are kind of struggling, still treat the delirium first, because you know it's the priority. So, as I said, there is new FDA-approved medication to treat delirium. But based on the guidelines and the research evidence, you know, scant evidence base, that if you have patient with hyperactive symptoms, agitation, hallucinations, that patient needs to be calmed down. You do all other intervention, as I said, non-pharmacologic, such as, you know, well-lit room, orienting patient, having family member present, same staff is attending, turn off the monitors, turn off the alarms, you know, prevent any kind of irritation. So you can start with Haldol, is still on first line, or olanzapine can be used as first line. Start with lowest effective dose and titrate up to effect. So risperidone you can give 0.5 to 1 milligram as an alternative medication. Between 1 milligram and 2 milligram, there is no difference when it comes to treating delirium. This is not like psychiatric illness that you're trying to control the symptoms. In psychiatric illness, you just give all of these antipsychotic medications much higher dose as a start if there's an emergency. So between if you increase the risperidone to 2 milligram, you may not see much, you know, effect if it comes to the treatment of delirium, but the patient may become very sedated. Same with Seroquel, quetiapine, 25 to 50 milligram should be fine in many cases, and increasing the dose would end up with increased sedation. We had cases downstairs, not every family member would want their loved one just, you know, go into some sort of coma state. They want to still interact with patient. It could be like very frustrating if we sedate too much. So the goals of treatment should be customized for these patients by communicating with families closely, and we know that high side effect profiles of these medications, so be careful. So typical antipsychotics are mostly used: Haldol, Tioridazine, Malarial. Malarial is used in geriatric demented population. It has more antidepressant effect, could be used as a long-term medication, but again, be careful. Anticholinergic effects are kind of bothersome, especially in elderly. Chlorpromazine, Thorazine can be very useful if the sedation is desired. It could be even your first line in certain cases. Haldol and chlorpromazine, as you know, can be given as an injection. The others are not widely used, and try to be familiar with similar medications and get used to dosing the properly. And the second line is atypical antipsychotic medications called as second generation. Clozapine has high adverse effect profile. We don't use much. Olanzapine, yes, we do. Risperidone, we use. Quetiapine. Ziprasidone is a new one. It has, you know, pretty much, again, side effects, anticholinergic effects, not widely used. Aripiprazole, which is Abilify, can be used in resistant cases for treatment of hypoactive delirium as an outpatient. It could be an option. if you gain familiarity with the medication, and it has to be again the lower doses, and don't bump it up easily. Yeah, you may combine, and we'll talk about the other options. So with this antipsychotics, there's an issue that, you know, since end of 90s and early 2000s, there are studies came out that there is high mortality risk in patients with dementia treated with antipsychotic medications. One of the studies, like the largest study from Veterans Hospitals, published in 2007. Since then, FDA has black box warning in these medications when it's used to treat elderly patients. Says that it has, you know, it can cause increased mortality risk, use on your own expense. So as a physician, you know, like you have a lot of medication with black box warning in a palliative care world. So what you're gonna do, you know, so you have to treat the patient too. So let's look at this study. This study done between 2001 2005. Number of patients involved were like more than 10,000. These patients were over 65-year-old, had dementia, and they were on psychiatric medications. And due to behavioral problems, they range from psychogenic medications, kind of like antidepressants, to atypical antipsychotic medication, or combination, atypical and typical kind of. So they followed these patients 12 months. Look at the graph. This is a very impressive graph. I love this graph, but you know, although we don't know exact reasons, but you can look on the left side, proportion of patients survive. So it's a survival curve over a year. Bottom shows the days. So if you the worst one, you know, the lowest survival was in the green. Combined conventional and atypical antipsychotics, they didn't do well, you know. If you combine Haldol with Seroquel, for example, they didn't do well. So on the long term, so, and they look at the reasons of death, you know, cardiovascular deaths, you know, other reasons. There was actually no big difference between the groups, actually, with this, you know, groups, but they died earlier. So we really don't know if it is because they required the combined conventional, atypical, and classical together, because their symptoms were very bad, and you know, they most like they had persistent delirium, and as we know from the previous studies, persistent delirium is correlated with increased mortality. So we don't know, but the outcome is when it's combined, and we are treating very ill patient with a lot of psychomotor symptoms, they don't do well. It could be that too. So the best one is the blue line. Other psychotropic medications. So patients required symptom management, treated with antidepressants, like, you know, more like mild agents, and required less medication, did the best. The ones had no psychotropic medication, the similar situation came first, and the survival expectancies. And the other one is the atypical antipsychotics, and the conventional antipsychotic was second worst survival curve. So this study caused the black box warning. Yes.
Okay, we were taught that, you know, atypical medication, atypical antipsychotic medications have better side effect profile compared to conventional antipsychotic medication. That is been known in the past, but however, recent study, I think published a few months ago, is saying that only Haldol, not other medication, actually have better side effect profile compared to even the atypical antipsychotic medication, especially when you're talking about certain cardiac death because
Yes.
antipsychotic can cause sudden cardiac
It is not antipsychotic is causing sudden cardiac death. It should have like underlying cardiac disease. Like if patient has arrhythmia, prolonged QT already, and you are titrating the antipsychotic, of course it may happen as like methadone patients too, like patients on methadone. So if it is used on patient with no underlying cardiac disease, as we know and we use all the time, and at the doses that up to 6 milligram a day, very gentle dose actually, it doesn't cause increased mortality. If you can control the delirium, because delirium is an emergency, and you may even prolong their life, right? You have to, but at the same time, you're also, as a mainstream medicine person, you're also controlling underlying factors. You're not just giving Haldol. Yeah. You have to treat patient, right? You're not just loading with medication. So in that case, if it is done properly, I'm sure it would prolong. I mean, I base my own anecdotal experience. I agree with that study, but I don't know what was the subject number and the underlying diseases. So there are many factors needs to be factored in to be able to make comment that the medication is causing high mortality or not. So the authors of the study did not say, okay, this is what we found, but it's difficult to explain why it's occurring. Is it because their symptom burden is heavier than patient requires just other psychotropic medication, which is most likely situation, right? You cannot just say, there are statistics shows that in summer, ice cream consumption and the drowning in the salt water increases, and there's correlation. There's no correlation, but you can find the correlation. If you so the statistics you have to use in a proper way, because it can come, it can give you any result. You can correlate anything.
It's also significant for the numbers. The
Yes,
numbers are
significant.
So different,
Yes.
for the different groups. That the two
Very,
groups that
very.
had the lowest mortality to begin with had the lowest sample size, so that
That's-
affects the numbers also.
Yeah, but it did cause a black box warning. That's why.
When you say other psychotropics, what exactly are we meaning with that? What is other psychotropics?
Antidepressants, so it's like Zoloft, Celexa, used in dementia-related behavioral symptoms, depression, but they did not require antipsychotic. Antipsychotics, most likely they did not have like severe delirium. It could be like hyperactive delirium, and there's a form of depends on how you diagnose delirium too. So there's another delirium like normoactive delirium. It's a new entity. So in that scenario, you have couple of findings of delirium, like cognition, declined cognitive ability, but you don't have psychomotor agitation, you don't have fluctuation maybe. So they are still defining as a normoactive delirium, because there's kind of sort of acute change for that patient, very subtle change. You may still treat that. So I don't know how they define delirium in this population. Right? We don't have those details, but it's pretty impressive data, though.
In the study, did they lump all causes of delirium together and treated all causes that needed to be treated?
Yes, they kind of
Throughout the span of the lifetime?
It's almost a year. No, this is like a structured prospective study. They diagnosed the delirium, ages over 65. They followed them, treated properly based on like underlying causes. Some responded just other psychotropic medications than antipsychotics, or resolved, like maybe they had dehydration, pneumonia, urinary infection, treated in the hospital, went home, and maybe a patient was on Celexa or Zoloft. Those are the medications they have used, and the patients had the best survival rate. So there's another medication group, mood stabilizers, that I use myself. if the most data published is around valproic acid Depakote. Carbamazepine can be used, but it has hematologic side effects, so I don't recommend to play with it just to treat delirium. Depakote can be used for treatment of delirium, especially in patients with underlying dementia, vascular dementia, with acute confusional change, and they have tried Haldol, other, and then ended up getting side effects like extrapyramidal side effects. You have not much room to use any other medication. Even they can have side effects, similar side effects with atypical ones, you know, with even Zyprexa itself, olanzapine can cause severe side effects. Valproic acid can be used alone or in combination with low-dose antipsychotic medication, and can, in my own experience, can create wonders. So you do use geriatric dose. Maybe first day I may give like 500 twice a day, and then go down to 250 twice a day or once a day, combined with very low dose Zyprexa or other atypical. It allows you to use less antipsychotic medication. It can be a very good mood stabilizer, and patients can improve dramatically. It is reserved for cases that patients don't do well with antipsychotic medications. And valproic acid can be given IV. That's another good side of it. So I had a case that patient came in from field, told like this patient has terminal delirium, have tried all other medications and psychiatrists involved, psychiatrists, and the patient had severe side effects with Haldol, risperidone. They couldn't take Zyprexa, so I kind of started valproic acid. Patient was described as like terminal delirium, unable to talk, screaming nonstop, not able to eat. Eventually improved to level that this patient, I didn't know, so learned later, was a poet. She started to say, you know, remember the poems that she has written, and she would cite it in a second. Would sing with her daughters, and start to eat by herself. It was amazing. So it is important to, you know, like every time when we come across with the delirium case, treat the underlying cause first too, and patient was that case, she had a urinary infection, dehydration too, and treat properly, and don't be afraid of using other options. Ativan and benzos. So do you treat delirium with benzos? What is the condition? So normally we don't. And it's only reserved for patients in delirium tremens, alcohol withdrawal. There's one exception. If it is real terminal delirium, you're giving medications, patient is still having motor agitation, you can use benzo because it's like there's nothing else left. Plus, if you use benzo as a first line just to pacify patient, it may cause paradoxical worsening of the confusional state and can cause, you know, worsening of delirium. And there are studies done with cholinesterase inhibitors like donepezil and rivastigmine to treat acute delirious state. Rivastigmine was used in a study in ICUs to treat ICU-related delirium. They had to stop the study because it increased the mortality. So there is no evidence-based support for donepezil, rivastigmine to treat delirium. It's not recommended, and it can increase mortality. Unfortunately, some had to die. Other options, clonidine. We use clonidine patch, especially because a lot of patients with terminal delirium, psychomotor agitation, they don't swallow, they don't cooperate, they spit out the pills. as my case that I mentioned before, she was spitting out the pills. It was bad, very bad case. So it could be used, especially when patient is hypertensive. You can give the medication and patient's delirious, so it can cause sedation, analgesia, anxiolysis, alpha-adrenergic medication, and it can be combined with other opioids, and it doesn't suppress the respiratory center, and it is also used, as you know, I don't know if any pain physician can know, that it's used for with treatment of opioid withdrawal or benzo withdrawal. The other one, I'm sorry, the colors did not come out well. Dexamethasone, it's used in ICUs as a sedative medication, alternative to Versed, alpha-2 agonist. It can be useful to treat to delirium. It cannot replace clonidine yet because it's very expensive. But the price may come down. It's new, as you know. And trazodone as a medication, antidepressant, has antidepressant effect and sedative effect. We use in elderly for insomnia. Can be given 50 to 300 milligram, and there's no evidence to support the use of trazodone in the treatment of delirium. In summary, delirium may affect 60% of the elderly patients in hospital and up to 30% of all patient population. Management of delirium is very complex. The primary emphasis has to be on diagnosis. You have to diagnose it first and treat the underlying factors. There's no FDA-approved medication. Haldol remains as first line in pharmacotherapy as sole agent. It can be used if there's side effects. You can move to atypical ones or mood stabilizers or clonidine. So you have some sort of relatively wide options, and it is still empirical management based on your clinical judgment and comfort zone with these medications, and the further research is still needed. Hopefully it will be done. That's it. Questions?